because of rheumatic heart disease. We see also young patients with heart failure. Now, non-communicable diseases are also alarmingly increasing in this country. We see also more prevalence of heart failure in the elderly population as well. So we are in a double health burden as far as heart failure is concerned, and as far as acute heart failure is concerned. When we did a small study in Ethiopia at our hospital, I'm part of this study, treatment outcome and its predictors among patients of acute heart failure, published in 2020 at BMC Cardiovascular Journal. In this study, we found that there is a high mortality. In-hospital mortality following acute heart failure is very high. It's alarmingly high, accounting about 17.2% of patients from acute heart failure admission died while they are in the hospital. And those patients having smoking history, those patients with diabetes mellitus, those patients having pulmonary hypertension, those patients who experienced adverse drug events, adverse drug reactions or side effects from medications are associated with a higher mortality and found to be predictors for mortality. When you compare this data with the registries that I showed you previously, that ranges from 4% to 11%, our mortality following acute heart failure in our setting is alarmingly very high because of resource limitation, because of the underlying cardiac disease requires surgery. Rheumatic heart disease is the commonest cause of underlying cardiac disease, and resource limitations in general to manage this group of patients contribute for a higher mortality. We are also expecting another study in the near future from the same hospital, and the result we expect will be the same or more than this. So the mortality in our setting is very high, so we have to give due attention for patients presented with acute heart failure. These are the spectrums of acute heart failure syndrome. In general, acute heart failure it compromises acute decompensated heart failure, which is the commonest cause that patients presented after decompensation from a chronic heart failure. So there are patients with acute chronic heart failure because of precipitants we will discuss in detail, will present with acute decompensated heart failure. Patients can also present with acute pulmonary edema as de novo or as a decompensation, which is also becoming a common emergency nowadays, acute pulmonary edema. Isolated right ventricular failure nowadays is also alarmingly increasing following pulmonary thromboembolism because of malignancy, COVID, obesity, other risk factors for deep venous thrombosis, and so on, as well as right ventricular infarction from coronary artery disease. Cardiogenic shock is also a severe form of heart failure that patients presented with cardiogenic shock following from several factors. So these are the spectrums of acute heart failure patients. So our patients presented with acute heart failure fall into either of the four categories. When we see the clinical presentation of this spectrum of acute heart failure, this is adopted from the European Society of Cardiology 2021 guideline, that acute decompensated heart failure, usually the onset is gradual, it takes more days. Main cause of symptoms are related to fluid accumulation and increased intraventricular pressure. Acute pulmonary edema is usually a rapid one. We found patients with acute flash pulmonary edema presented with acute respiratory failure. One of the causes is acute pulmonary edema, and it is also a very important differential diagnosis for ARDS. The other is isolated right ventricular failure, could be rapid following pulmonary thromboembolism or following myocardial infarction, right ventricular infarction, or it could be gradual from pulmonary hypertension or from core pulmonary or from other causes of pulmonary hypertension as well. Cardiogenic shock can be gradual or rapid. So to assess this, in general, patients presented with acute heart failure, we need to assess evaluate first patients. This is adopted from the American College of Cardiology 2020 guideline. Last year, we had a very interesting, resourceful, evidence-full guideline from the American College of Cardiology, American Heart Association, and the class of recommendation is one that every patient with acute heart failure should be the precipitant factors should be addressed. Okay, address precipitating factors. It is a class 1 recommendation. These precipitating factors are: it could be acute coronary syndrome, it could be uncontrolled hypertension, it could be arrhythmia. The commonest arrhythmia that we usually encounter in our population is atrial fibrillation. It could be an additional cardiac disease that patients do have, for example, a valvular heart disease. Patient might develop another valve lesion, cardiomyopathy, for example, or myocarditis or infective endocarditis that can precipitate acute heart failure. Or it could be non-adherent to medications or
Hello everyone. I think Dr.Desalew is having a problem with the connection. We'll try to figure it out and get him back as soon as possible. Sorry for the inconveniences, and please bear with us.
Until then, you guys can post your questions on the Q&A section. If you have any question so far throughout the presentation, you can make sure to post your questions.
Hello everyone. Yes, we have noticed it's interrupted. Dr. Desalew is having a connection with problem. We're trying to work on it and get him back as soon as possible. Please bear with us. Thank you and sorry for the inconveniences. As for the slides, we will be uploading the slides after the session is done on our Telegram groups. So make sure to join our Telegram group and subscribe to our YouTube channel as well. Kali will be sending the link tree in the chat box again. Please make sure to check it out. Thank you, everyone.
Okay, I've sent a question on the chat section saying the previous seminar slide is not posted. I will make sure to make it available. And I have shared you a Google form, so it will be useful for us to prepare your certificate, CU points. So please make sure to fill that in the meantime.
Hello everyone. For the inconveniences, the Google form link will be sent at the end of the session since it's supposed to be a post quiz. You can see the results as soon as you fill them after the quiz, after the session, and your certificates will be sent in about 1 to 2 weeks. We apologize for the inconvenience. The Google form sent was not the appropriate one. We will send it right after the presentation is over. Till then, make sure to join our Telegram groups, subscribe to our YouTube channels, and as well, do not forget to send your questions to the question and answer session. I think we have Dr. Desalew back, so we will continue with the presentation shortly. Thank you for your patience.
Hello, is someone?
Yes, Samal, Dr. Desalew.
Is the slide visible?
Yes,
Yeah,
it is
sorry
visible.
Sorry for the inconvenience that has happened from my end. So these are the precipitants that I have already mentioned. So when we assess patients with acute heart failure, we have to think about this Foster diagram. We have to draw a 2x2 line, considering one arm, the lungs, one arm, the perfusion status. And then when we assess the lungs for congestion, for the presence of pulmonary congestion, evidenced by clinically with orthopnea, paroxysmal nocturnal dyspnea, peripheral edema, jugular venous distension, congestive symptoms like congested liver, and the presence of gut congestion. We call it wet and dry. If there is no congestion, we call it dry. If there is congestion, we call it wet. And then we will assess also the perfusion status of the patient by looking for cold extremities, the reduction in urine output, the presence of evidence of brain hypoperfusion in the form of mental confusion, dizziness, and by assessing also NRO pulse pressure. For example, if the difference between the diastolic and systolic blood pressure is very low, then we call that patient is having hypoperfusion. Then we call that is cold. So patients can fall into either of the these two categories. Either the patient could be warm or could be cold. So with these four categories, we assess a patient, and our patient will fall into either of these four categories. So majority of patients fall into the category of warm and wet. About 67% of patients fall into having a normal perfusion with congested lungs, and only a small amount of patients fall into a cold and dry. These cold and dry patients are usually acute pulmonary thromboembolism, acute right side heart failure, acute coronary syndrome from right ventricular infarction, and about 25% of patients will be present with shock as well as congestion. This is having a very worse prognosis during management. We have to note that hypoperfusion and hypotension are not the same. A reduction in blood pressure doesn't mean that that patient is hypoperfused. So we have to assess patient's perfusion status by clinical parameters as well to say that this patient is hypoperfusion, having hypoperfusion or not. Reduction in blood pressure alone is not a sign of hypoperfusion. So the other, this is what I have already mentioned. So when we evaluate patients with acute heart failure, this is an algorithm from the American College of the European Society of Cardiology 2021 guideline, we have to take a proper history and assess symptoms, as well as we have to capture some signs specific for acute heart failure. Then followed by, we have to investigate the patient. ECG is very important. We have to monitor his oxygen level. Brief bedside echocardiography is very important. Initial laboratory investigations, especially basic laboratory investigations, like the renal function test, electrolytes, the thyroid stimulating hormone, liver status. If there is a high index of suspicion for pulmonary thromboembolism, D-dimer, if there is a suspicion of infection, procalcitonin level are very important. Chest X-ray to look for the lungs for infection as well as for congestion. Nowadays, lung ultrasound is evolving to look for presence of congestion and infection. Then, if we didn't get adequate evidence for acute heart failure, we might go into cardiac biomarkers, heart failure biomarkers, NT-proBNP and PNP, and NT-proBNP is more specific. This is needed if we have a doubt. Otherwise, if there is a clinical sign for pulmonary or systemic congestion with symptoms, that is enough for diagnosis of acute heart failure. So regarding guideline medical therapy during hospitalization, we often discontinue guideline oral medications for a guideline-directed medical therapy for those patients having a chronic heart failure. While they are on treatment, they might have a decompensation, acute decompensated heart failure. We usually discontinue, but that is not the case. The American College of Cardiology 2022 guideline advise us, unless contraindicated, guideline medical therapy should be continued, including beta blockers should be continued as it is while patients are admitted. And we have to continue diuresis despite a mild reduction in renal function. We often discontinue diuretic because of an elevated in creatinine. That's not the case. That's not the case. Diuresis should be continued despite a reduction in renal function, despite elevation of creatinine, as well as a low blood pressure, because congestion might be the cause for that. Patients might have cardiorenal syndrome, renal vein congestion, that is a contributory for the cardiorenal syndrome, so diuretic should be continued. And the other advice regarding guideline medical therapy is reinitiation and also optimization of guideline medical therapy while patients are clinically stable, and before discharge, we have to initiate this guideline-directed medical therapy, especially for those patients having heart failure with reduced left ventricular function. The other thing is venous thromboembolism prophylaxis is recommended for all patients hospitalized for acute heart failure. Venous thromboembolism prophylaxis, DVT prophylaxis is very important. When there is a low cardiac output, if patients are severely congested, having a severe volume overload, and if the patients do have heart block, bradycardia, symptomatic bradycardia, and if there is a significant congestion, we have to discontinue beta blockers, of course. And the same applies to ACE inhibitors and ARNI for those patients having significant hypotension, as well as having angioedema. So these are the guideline advices in the management of oral therapy in acute heart failure in the first 48 hours. Which one to continue, which one to stop? We should be guided based on this advice. ACE inhibitors and ARBs, if patients are normotensive or hypertensive, we have to increase the dose. If patients are hypotension, for example, a blood pressure, a systolic blood pressure of less than 100 millimeter of mercury, we have to reduce. If it is less than 90, we have to stop. And heart rate, the potassium level, renal impairment, this is the guidance that we have at hand, which drugs to discontinue, which drugs to increase, which drugs to reduce their dose. This is the recommendation. So when we discontinue, increase or decrease any of these molecules, we have to think about these important variables: blood pressure, heart rate, potassium level, renal impairment, creatinine value, the cut point is 2.5. So we have to think about that. So these are the goals of treatment in acute decompensated heart failure. The immediate, while patients are in the emergency department or in the ICU or in the coronary care unit, our main goal is to improve hemodynamic status as well as to ensure organ perfusion. We have to restore oxygenation, to alleviate symptoms if patients are having short of breath or chest pain or having symptoms, we have to alleviate that, limit cardiac and renal damage following administration of these medications, prevent thromboembolism by administering DVT prophylaxis. We have to also minimize ICU length of stay. The decongestion strategy. This is a guideline from the American College of Cardiology. During decongestion, our initial management should be using IV loop diuretics. In our case, the most available IV diuretic in our setting is furosemide. Furosemide should be administered intravenously in patients present with acute heart failure. And we should also titrate the diuretic based on patient response and based on urine output and based on the change in the clinical parameters in the patient. And during monitoring, we have to look for fluid intake and output, fluid balance, daily weight, which is very important, clinical signs of congestion. We have to see the JVP, we have to see the lungs, we have to see the elevation, the improvement of the liver congestion, look for hypoperfusion status improvement, and laboratory monitoring, especially electrolytes, sodium and potassium, and creatinine are very important monitoring parameters that we have to use during acute heart failure management. During titration, based on the patient's response, we can double IV loop diuretics. It's a class 2A recommendation. Loop diuretic infusion is a class 2A infusion. By the way, the dose trial advised us that bolus administration, intermittent bolus administration, as well as continuous IV infusion of furosemide is the same in clinical outcome of patients with acute heart failure. But we might choose for, based on the individual patient, we might choose continuous furosemide infusion or intermittent bolus infusion. So the other is use of other agents like the addition of thiazide diuretic in the optimization of diuretic therapy. Still it's a class 2A recommendation that should be individualized. Nowadays, to improve diuresis, astazolamide administration is also advisable. We will see the trial, the ADVORT trial later on in this presentation. So this is the algorithm from the European Society of Cardiology that we follow in the management of acute heart failure. Once patients are on oral loop diuretic, that should be the same oral dose, should be changed into IV and should be administered IV. And we follow the urine output and we optimize based on the patient's response. By the way, this algorithm will not apply to every patient. So our administration of loop diuretic should be individualized. It should be individualized to that particular patient. So during monitoring, this one I have already mentioned, at least daily, we have to measure their weight. At least daily, we have to assess the fluid intake, output, and input. More than daily, we have to monitor the vital sign, usually in most settings, every 6 hours. At least daily, we have to assess their signs of edema, ascites, pulmonary rales, hepatomegaly, the JVP, the hepatojugular reflex, the liver tenderness. At least daily, we have to also assess the symptoms like orthopnea, paroxysmal nocturnal dyspnea, or cough. The fatigue status, clinical status of the patient should be assessed. So another important information is about supportive therapy. We believe that oxygen is helpful for every patient with acute heart failure, but that is not true. oxygen is recommended in patients with oxygen saturation of less than 90%. So we shouldn't administer oxygen overzealously for every patient with acute heart failure because it is a vasoconstrictor. It constricts coronary arteries. So for those patients having normal oxygenation, oxygen is not recommended. It is a class 1 recommendation, but the level of evidence is C. Intubation is recommended for progressive respiratory failure persisting in spite of oxygen administration or non-invasive ventilation. This is a class of recommendation 1, level of evidence C. Non-invasive positive pressure ventilation should be considered in patients with respiratory distress of respiratory rate more than 25 breaths per minute and those desaturating to the extent of oxygen saturation of less than 90 and started as soon as possible in order to decrease respiratory distress and reduce the rate of mechanical endotracheal intubation. It is a class 2A recommendation, level of evidence B. So these are the recommendations regarding oxygenation. The other thing that I have already mentioned is about diuretic. Diuretic administration should be intravenous for all patients with acute heart failure admitted to a hospital with signs and symptoms of fluid overload to improve outcome. Diuretics are important. We should consider combining of these diuretics if patients do have a resistant edema who are not responding to an increased dose of loop diuretics. Still, the class of recommendation is 2A. Vasodilators are indicated for those patients having acute heart failure, especially those patients having a systolic blood pressure of above 110 millimeter of mercury. So these vasodilators, nitrates, are more of important in patients having acute pulmonary edema in the case of hypertensive heart disease. Otherwise, those individuals having lower blood pressure, systolic blood pressure of less than 110, and those patients who took sildenafil, these vasodilators might be deleterious, might result significant hypotension in those individuals with acute heart failure. Inotropic support. These inotropic agents might be considered in patients with having significant hypotension, a systolic blood pressure of less than 90 millimeter of mercury, and evidence of hypoperfusion who do not respond to standard treatment, including fluid challenge to improve peripheral perfusion and maintain end-organ damage. So inotropic agents, the preferred inotropic agent now recommended is norepinephrine, but sometimes we might administer dopamine in those patients who are not responding to norepinephrine, or we might put patients on a double pressor as well. So vasopressor therapy is indicated in such situations. Another recommendation for in the management of acute heart failure is the use of thromboprophylaxis. DVT prophylaxis is recommended for all patients, in patients who are not in anticoagulation. And if there is no, and those without contraindication, all patients should be anticoagulated. Prophylactic anticoagulation is recommended with low molecularity heparin, or in our case, unfractionated heparin can be used. And this is a class of evidence 1, level of evidence A recommendation that every patient with acute heart failure admitted to a hospital should receive DVT prophylaxis. The other is previously in the previous guidelines, management of anxiety and pain was recommended by administering opioids. Nowadays, it's a class 3 recommendation, almost not recommended to use routinely these opioids like morphine in patients with acute heart failure. The other thing is the transition of care. We manage patients in the hospital. Then after optimization of acute heart failure therapy, we have to discharge these patients. But before discharge, we should have a transition plan, transition of care. These patients are now transitioned from acute care to a chronic care. So in this case, we have to consider early follow-up. That's very important. We shouldn't discharge a patient in leave. We have to give appointment. Ideally, within 7 days, patients should be appointed and should be re-evaluated. And we have referring these patients to a multidisciplinary heart program. So patients might require multidisciplinary management. They might have, they will have risk factors like diabetes. They might have concomitant renal disease. They might have concomitant malignancy. Now we are getting more cases of cardio-oncology because cancer treatment is now advanced, and these cancer medications are having an impact in the heart. So we have to link these patients to multidisciplinary team. Participation in benchmarking programs to improve guideline medical therapy and quality of care issues, addressing precipitate causes of and high-risk factors like comorbidities, adjusting diuretics, coordination of safety laboratory check like renal function test, electrolytes. This is very important that we have to consider during a transition of care. So before discharge, we have to think about up titration and monitoring of pharmacological therapy, especially thinking about guideline-directed medical therapy. We have to need timing for review for further therapy, who will see the patient for follow-up and when, enroll in disease management programs, educate and initiate appropriate lifestyle adjustments, prevent early readmission, and we have to think about how to improve the quality of life of these individuals as well. So now we have a heart failure registry. We are now launching as Ethiopian Society of Cardiac Professionals, launching heart failure registry. So it's better to have that registry in your facility and register these patients so that follow-up will be easy through that platform. The other, this is from the European Society of Cardiology. It recommends about optimization of heart failure, improving the congestion status, initiation of evidence-based medical therapy, especially for those patients having heart failure with reduced left ventricular function. We have now a guideline-directed medical therapy. Patients should be put on RAS blockers, beta blockers, SGLT2 inhibitors, and so on. We have to also consider about iron therapy, especially those patients having iron deficiency and heart failure. Ferric carboxymaltose iron supplementation is very important, even though it is a 2A recommendation. Now evidences are evolving that iron administration improves symptoms and reduce rehospitalization in those patients really having iron deficiency in the presence of heart failure. So comorbidity management is very important. If patients are hypertensive, then we have to address that hypertension based on the guideline. If patients are diabetes, then we have to address diabetes with agents having a benefit for that heart failure. Especially now, evidences are evolving for the use of sodium glucose transport inhibitors, SGLT2 inhibitors like dapagliflozin, which is available in our country, canagliflozin, empagliflozin, dapagliflozin. These agents are now coming so that we have to use that. Those patients having coronary artery disease and having left ventricular dysfunction, then we have to think about revascularization, either with PCI or surgical revascularization. Patients with valvular heart disease or cancer, multidisciplinary management is very important. Valve surgery, cancer management. Patients with atrial fibrillation should get anticoagulation to prevent further thromboembolic events like stroke and peripheral arterial disease. So this is a class 1 recommendations in green. Those patients having iron deficiency, iron should be supplemented. Those patients having rhythm abnormalities, which is mandatory for reverting rhythm, like heart failure with atrial fibrillation, for example, if there is a need for a sinus rhythm to improve their heart failure, then nodal ablation is recommended. Device therapy now is in place also in heart failure with indication. Patients with obstructive sleep apnea, we have to link into a CPAP after a sleep study. Those patients having heart failure with reduced left ventricular function and cancer, guideline-directed medical therapy is indicated. As you see, in cancer patients, the left ventricular ejection fraction cut point to say that heart failure is reduced is 50, not 40, okay? Unlike other patients in cardio-oncology, the cut point for left ventricular ejection fraction is 50. This is set for early optimization of heart failure in cancer patients. A recommendation for managing comorbidities in patients with heart failure, this is already mentioned. So that early optimal therapy is very important. There are evidences that when patients are admitted to a hospital repeatedly, then the chance of death is very high. Okay, the chance of death is very high. So this, if patients are admitted for the first time, the second time, the third time, so death is more imminent. Once these first admitted, for example, this patient this time is admitted, then the death is much closer. This patient was admitted at this, then death is more imminent when patients are repeatedly admitted. So that repeated admissions, one of the goals of heart failure management is to avoid or reduce hospitalization. So one of the ways that we reduce hospitalization is early initiation of guideline-directed medical therapy. Now we have evidences that early optimal therapy can prevent hospitalization and can lead for a better outcome. One of the evidences is the Pioneer Heart Failure Trial, which is published in 2018 as the New England Journal of Medicine. In hospital administration of sacubitril valsartan, angiotensin neprilysin inhibition has a better reduction in a change in NT-proBNP. As I have told you, NT-proBNP is a prognostic marker in the first 8 weeks. So, and the separation of the curve, as you see, starts from the first week. So early initiation of, rather than delayed initiation, early initiation is better, and even better molecules. This study compares early initiation of enalapril versus early initiation of sacubitril valsartan. Initiation of sacubitril valsartan is associated with a more reduction in NT-proBNP. It doesn't mean that enalapril can't reduce NT-proBNP. As you see in the curve, enalapril can also reduce the NT-proBNP level as compared to the baseline, but sacubitril valsartan has a better decrement. That means patients will have also a better outcome in the future. So this is also another study called the transition study. Even patients who started guideline-directed medical therapy of sacubitril valsartan before discharge do have a better outcome when comparing about the evidence of survival, worsening heart failure, and also the rehospitalization rate is significantly reduced. Another evidence is from the Impulse study. This Impulse study, the article was published in 2023, last January, but the article was presented at the American College of Cardiology Annual Congress last April. It says that early initiation of SGLT inhibitors in empagliflozin while patients are hospitalized for acute heart failure has a better outcome than those patients who didn't start medication in terms of heart failure events, as well as in terms of composite outcomes of cardiovascular outcomes like cardiovascular death, heart failure hospitalization, and also the Kansas City Cardiomyopathy Questionnaire. This is a quality of life questionnaire for heart failure, and as you see, the p-value is significant. So early initiation of guideline-directed medical therapy while patients are hospitalized is very important. And it's also a golden opportunity to initiate these molecules while patients are discharged, while patients are hospitalized. This is also another new evidence that we have that was presented last time at the European Society of Cardiology Annual Congress in September and published in New England Journal of Medicine, called the ADVOR trial. This is for decongestion. Acetazolamide, which is a carboxylase inhibitor, administered on top of intravenous loop diuretics for decongestion. And those patients who received 500 milligram of acetazolamide intravenously, in addition to their diuretic, do have a better decongestion, a greater incidence of successful decongestion. By the way, early decongestion, early elevation of congestion is associated with a better survival and a better recovery from their symptoms. So this is a very good trial that this old drug acetazolamide is coming into in the management of acute heart failure. It's not yet incorporated in the guidelines, but in the future, I hope it will be incorporated in the guidelines. So guideline-directed medical therapy has been reviewed and patient has been stable for 24 hours. Should be, you have to, after stabilization, we have to start that. Potential exacerbating and confounding comorbidities should be addressed. This is a checklist. Exercise tolerance has returned to NEA class at least 2 before discharge. Volume status should be optimized. Education has been provided and clinic follow-up should be scheduled. We have to check all this before we discharge patients after a stabilization of patients with acute heart failure. So what are the prognostic markers? Which patients are really at high risk of mortality? The most important prognostic marker is systolic blood pressure. As the systolic blood pressure is below 140 millimeter of mercury, then risk of in-hospital mortality is very high. As you see, the difference between 140 to 160 and greater than 160 is 1.7 to 2.5, but between 120 to 139 and less than 110 is almost doubled, and the same applies to 60 to 90 day mortality. This is a mortality most probably after discharge. So systolic blood pressure nowadays is becoming an independent predictor of mortality in acute heart failure. The other prognostic marker is BUN, which is also a strong predictor for mortality. If BUN is greater than 37 milligram per deciliter, then these patients are at high risk of mortality. So these patients should be, we have to keep an eye. Other factors of concern, but with less impact on mortality, are serum sodium, low serum sodium, elevated serum creatinine, advanced age, dyspnea at rest, congestion despite diuresis, which is refractory fluid overload. These are predictors of mortality as well. So another thing that we should give due attention is a quality of life in patients with acute heart failure. So these patients with acute heart failure will have sleep disturbance because of the orthopnea, PND. They will be anxious. They will have a cognitive dysfunction. They will be depressed. They will have also abdominal symptoms because of the congestion, like bloating, constipation, lack of appetite. They will have also dyspnea, fatigue. All these result in a poor quality of life. So optimal management of acute heart failure will also improve their quality of life. So now in heart failure management, quality of life is now becoming one of the parameters. The Kansas Cardiomyopathy Questionnaire is one of the parameters in clinical trials that quality of care is also taken into account. So this is my last summary slide that I have already said. So thank you very much. This is the end of my slide. So if you have questions, comments, suggestions, then you are welcome.
Thank you, Dr. Desalew. Everyone, please keep sending your question to the question and answer box. We already have around 5 questions, so I think we can get started on those. And as we go on, if you have any other question, please make sure to send it to the question and answer group. So, Doctor, can you see the questions? Dr. Desalew?
Yes, yes.
Okay, so our first question reads, is BNP available in our country for diagnosis of heart failure and to predict prognosis?
Yeah, BNP is available. Pro-BNP is available in our country. The most important problem is it is very expensive. It's like 900 per test. Otherwise, it's available in our country. Second question,
Okay.
I didn't see the question, so can you?
Okay, second question reads, what is the definition of resistant edema?
Yes, this is also a very important question. Resistant edema or refractory edema is while patients are on optimal management of diuretic, and if patients are fail to respond to the diuretic administration, then you can call it refractory edema, persistent edema, because this is a clinical definition. It varies from one patient to another patient. It's the managing physician who defines that patient has a refractory edema. So after maximum administration of diuretics and considering the patient's blood pressure. So it is a subjective definition that the treating physician defines. By the way, before declaring refractory or persistent edema, a case discussion should be needed. At least a team of doctors in the vicinity should discuss and decide that this patient has a refractory edema. How can we able to optimize? Are we going to start intravenous continuous infusion? Are we going to add another diuretic agent, adding, for example, thiazide diuretics, or optimizing the dose of spironolactone, or to the extent of ultrafiltration with the dialysis machine, we can remove fluid with ultrafiltration. But this requires, it has no a clear definition, but it's just a subjective definition.
Okay, thank you, Doctor. Third question, which type of antipain is preferable in acute heart failure?
Yeah, in patients with, usually in patients with acute heart failure, they don't have pain, that much pain in patients with acute heart failure, unless they do have acute coronary syndrome, while these patients do have chest pain. Nowadays, the best treatment for chest pain in acute coronary syndrome is reperfusion therapy. You have to open the blocked vessel so that improve their oxygenation, so that chest pain will be alleviated. Or you have to use vasodilators, nitrates, unlike other pain. And the other analgesics that those patients having severe chest pain, we might use morphine, we might use plus or minus pethidine. Otherwise, they will not have pain. Patients with acute heart failure are not, will not have that much pain. As much as possible, we have to avoid non-steroidal anti-inflammatory drugs. One, it will result the edema more refractory. Second, it will induce acute renal failure. So non-steroidal anti-inflammatory drugs should be avoided as much as possible. The same applies to overzealous administration of paracetamol. These patients do have also liver congestion. So overzealous administration of paracetamol will lead for more further liver damage as well. So as much as possible, we have to be very cautious in administering analgesics, unless otherwise indicated.
Okay, our first question reads, what do you suggest on the management of severe symptomatic hyponatremia, in addition to diuresis and safety of hydrochlorothiazide in patients with hyponatremia? So I think that will be 2 questions. The first one will be, what do you suggest on the management of severe symptomatic hyponatremia in addition to diuresis?
Hyponatremia management needs a nephrology consultation. So that's very important. If you have a nephrologist available, you have to consult. Otherwise, the cause should be defined first. What is really the cause of that hyponatremia? In heart failure, we expect dilutional hyponatremia because of more fluid retention, and it's also associated with poor prognosis. That you have to define first the cause for that hyponatremia. Even diuretic administration might also worsen the hyponatremia as well. So cause should be first defined, and if you have also blood gas, then blood gas is also helpful in this group of patients if there is concomitant renal impairment. And the other thing, you have to follow the algorithm for hyponatremia management.
Can I chip in, Dr. Desalew, here on this topic as a nephrologist?
Okay.
Yeah. So, like Dr. Desalew said, this is if hyponatremia and acute congestive heart failure is related with volume, your target is indicated diuresis. You shouldn't be looking at, of course, you'll be looking at the sodium levels, but this is volume related. So you have to target indicated diuresis either with a combination of loop diuretics, and if needed, you can add thiazide like diuretics to achieve your diuretic goal. So in acute heart failure, it is volume related, and even if you add thiazide diuretics, you're not going to be worsening it. When you indicate urine output, your sodium level should be improving. But otherwise, if things are worsening, of course, you're going to be looking into the urine electrolytes, urine osmolality, and other numbers to adequately diagnose where is the hyponatremia coming from. But if it's acute CHF related, definitely don't hesitate to manage diuresis with both loop diuretics and thiazide diuretics. Thank you.
Yeah. Thank you very much, Dr. Kulsum, for the supplement. Yeah.
Thank you, Dr. Kulsum. The next question reads, diuretics dose titration strategy, including frequency in pulmonary edema, every 2 hours or 6 hours?
Usually, IV diuretic administration, the action starts after 30 minutes to 1 hour. So you have to assess after administration, after 1 hour, you have to assess. And based on the patient, you might also assess after 2 hours. So you shouldn't wait until 6 hours after administration of IV diuresis. So frequent evaluation is recommended. No, we shouldn't delay for 6 hours.
Thank you, doctor. The next question, recommendation regarding digoxin.
Digoxin in core pulmonary, it says. Yeah, nowadays the indication for digoxin is coming down, especially it is indicated in patients with atrial fibrillation and hypotension, having fast ventricular response. Otherwise, indication for improving contractility is reserved for those patients having advanced heart failure. So we should, especially in patients with core pulmonary, we should be very cautious. These patients are hypoxic and hypovolemic. The risk for digoxin toxicity is very high. So digoxin is reserved for those patients having atrial fibrillation with fast ventricular response and having a lower blood pressure that we can't, or having significant edema that we can't administer beta blockers.
Thank you, doctor. The next question, what is your experience on IV iron for heart failure?
Yeah, if there is iron deficiency, we administer IV iron. By the way, IV iron is the one which is recommended for the management of iron deficiency in heart failure. So we give patients with iron deficiency IV iron.
Okay. If patient is congestion with low blood pressure, how do we manage?
Yeah, low blood pressure, hypotension and hypoperfusion are two different things. The most important thing is whether your patient is hypoperfused or not. Otherwise, hypotensive patients can be diuresed. You should follow their perfusion status. In terms of the patient status, you have to palpate his pulse, look for evidence of cerebral perfusion, the urine output, extremities, the pulse strength. Otherwise, blood pressure alone is not a contraindication for diuresis. So if patients are hypoperfused and congested, then these patients fall into a category 4. These patients are cold and wet. So these patients require inotropic support, administration of norepinephrine or dopamine to increase the blood pressure. At the same time, you have to decongest them as well. So hypoperfused patients are not hypotension is not a contraindication for diuresis. Rather, with diuresis, patients' blood pressure might improve. The congestion might be the cause for the cardiac suppression. So hypotension is not a contraindication for diuresis.
Okay, doctor. So the next question is issue of beta blockers for patients with acute heart failure with atrial fibrillation in elderly patients.
Yeah, I have clearly put the contraindications for beta blockers. The presence of bradycardia. Elderly patients might have concomitant heart block. So if patients are bradycardic, if there is significant left ventricular dysfunction, if there is significant congestion, we have to avoid beta blockers. Otherwise, beta blockers can be administered to control heart rate in patients with atrial fibrillation, even in elderly population. So if patients are contraindicated for beta blockers, we can administer other agents. One agent is digoxin. The other is amiodarone, which is also available in our setting, especially can be used in for a short period of time in hospitalized patients.
Okay, doctor. The next question is, what is the maximum furosemide dose to define diuretic resistance, and how do we manage a patient having both pulmonary edema and cardiogenic shock?
Very good. So, by the way, furosemide can be administered up to 800 milligram to 1,000 milligram per day, based on the response of the patient. Even there are also high dose preparations, especially if there is an issue of renal failure, concomitant renal failure, diuretic response is very limited. So you can administer diuretics to that extent, despite the occurrence of concomitant diuretic related side effects, especially side effects in the ear and electrolyte imbalances as well. So there is no specific dose that you can say that this patient is diuretic resistance. The other thing is the presence of hypotension and hypoperfusion. I can say hypoperfusion and hypoperfusion. In the Foster 2x2 table, these patients are cold and wet. So these patients, first we have to give priority to perfusion because hypoperfusion is more lethal. They do have more vital organ hypoperfusion, worsening of renal failure, brain dysfunction, and so on. So we have to support blood pressure with diuretic, with inotropic agent like norepinephrine. And at the same time, we should start diuresis. By the way, this group of patients account about 25% of acute heart failure patients, and the 6 months mortality is also very high. It is around 40% of patients die within 6 months. If they survive from the hospital, the risk of days after discharge is very high.
Okay, the next question reads, what is the relationship between hypertension and cardiac failure?
Yeah, hypertension is one cause for acute heart failure. Especially those patients present with flash pulmonary edema, one of the most important causes hypertension. We call it acute hypertensive heart disease. So hypertension by itself can result in acute heart failure, and uncontrolled hypertension and unaddressed hypertension can result in burnout cardiomyopathy, with that the pump will fail and patient can present with heart failure. So it is a very important cause for heart failure, as well as an important cause for precipitation. It is a precipitant as well. It's a precipitant, especially individuals with renal failure. They will have hypertension can be a precipitant for acute heart failure.
Okay. So the next two questions read, how long should we give anticoagulant after discharge? And in a primary health facility, what is the minimum means to diagnose acute heart failure?
Yeah, prophylactic anticoagulation for DVT should be administered while patients are in the hospital. After discharge, we have to discontinue unless the patient do have atrial fibrillation that requires anticoagulation for their atrial fibrillation. Otherwise, after discharge, it should be discontinued. Prophylactic anticoagulation with either unfractionated heparin or low molecular heparin should be administered while patients are in the hospital setting. And after discharge, this anticoagulation should be discontinued. But if patients do have an atrial fibrillation, based on the CAD-VAS score, then these patients definitely will fulfill a CAD-VAS score of 2 and above. Then patients should be on therapeutic anticoagulation for atrial fibrillation. Acute heart failure, by the way, from the universal definition in general heart failure is a clinical diagnosis, by the way. It doesn't require any investigation unless we have any doubt that the dyspnea is of pulmonary origin or not. And if there is any doubt of differentiating that, we don't need a BNP for all patients to diagnose heart failure. It's a clinical diagnosis. Signs and symptoms of heart failure. Symptoms like dyspnea, paroxysmal nocturnal dyspnea, orthopnea, body swelling, and cough, and so on, palpitation, plus symptoms of either pulmonary congestion, like having chest rails, an elevated JVP, right upper quadrant tenderness or hepatomegaly, appreciation of murmur, especially S3, gallop, presence of peripheral edema. These are evidences of pulmonary and systemic congestion plus symptom. That is, fulfills the definition for heart failure. If there is any doubt, then we go for further investigations. Even in without the absence of the facilities in primary healthcare levels as well, we can diagnose acute heart failure. It's a clinical diagnosis. If there is any doubt, we can add ECG to look for some changes. We can add a chest X-ray to look for the lungs for congestion as well as for a precipitant of heart failure. We can see an ultrasound of the chest for a presence of congestion, effusion, or abdominal ultrasound to look for the internal jugular vein, whether it is full or empty, collapsed, and so on. So this acute heart failure diagnosis doesn't require a sophisticated facility. It only requires your skill and a background knowledge.
Thank you, Dr. Desalew. We've been having very active engagement from the webinar attendees so far, and we're getting a lot of good answers from our speaker. We'll be sending the links for registration and the questions. Please, all of you who are attending this webinar, make sure that you have filled out your name, your title, your email correctly, and make sure that you answer the questions. All the questions are based on the presentations from today. So when we share, take time to review the question and answer them. Anyone who gets 50% and above will be able to get continuous education unit credit from Ethiopian Society of Cardiology. We will continue with the discussion. We'll try to be brief so that you can get time to answer the form. Dr. Desalew, what's your experience on using ultrafiltration or dialysis for heart failure in our setup? That was the next question.
Luckily, I have a colleague, a nephrologist colleague who works with me. We had experience for refractory fluid overload, despite in the absence of significant renal indication for ultrafiltration. We go for ultrafiltration and we see a good result. Recently, last month, we did that. When Dr. Brook was also part of this patient's management, a patient presented with refractory pulmonary edema, despite having 3 liters of urine output. Patient went repeatedly with refractory pulmonary edema, and we did ultrafiltration. The same applies to systemic congestion. We are more successful in those patients having pulmonary edema than those having systemic congestion. Those with having systemic congestion tend to be more hypotensive and not good candidates for ultrafiltration. Their blood pressure didn't allow for ultrafiltration. They didn't tolerate the ultrafiltration despite the pressure support. But those having refractory pulmonary edema from hypertensive heart disease especially, they benefit from ultrafiltration. And with the joint management, team management, multidisciplinary team management is very helpful. For that, I am lucky having a nephrologist at my side, and he's really very instrumental in hyponatremia management. It doesn't worry me much about hyponatremia, and as well as in those patients requiring ultrafiltration.
Perfect. I think that's a good setup to have. Probably if we had the other type of dialysis, which we use in the ICU setting, a continuous renal replacement therapy, we can use in hypotensive patients. That could be an answer for the kind of patients you're unable to do ultrafiltration, but I don't think we have that set up in our country. You have a lot of other questions, so I'll try to lump together questions together so that we can get over the questions and do the forms. I believe the form has been shared already. It's a Google form that asks your name and your title and then questions with it. So as soon as you fill and complete it, you will be able to know your scores. So the next question is from Dr. YetenaWeg. He's asking, what is the clinical outcome or outlook for patients with medical treatment alone in a setup where you don't have surgical, you don't do surgery or any PCI?
This is for structural, those patients having structural lesions, especially valvular disease, then medical management is just a bridge. It's just a bridge. It is a transition care for surgery. Otherwise, it will be a futile exercise. You just decongest them, they get congested again, they develop atrial fibrillation, rapid response. It's just a transition of care. For those really having structural heart disease, we have to encourage our people to go for surgery, and we shouldn't give hope that medical management will have. Luckily, we have cardiac surgeons in our country. They are doing an amazing work in this regard, and we have to encourage them. For coronary, still optimized medical care helps. There are also clinical trials. So in the absence of PCI, as well as in the absence of coronary artery bypass graft, still optimal medical therapy might help for those patients having a coronary artery disease. And we have also patients who improved with optimal medical therapy. But if there is an access still for that, we have to give that offer to patients. But we have to assess the economic status of the patient. If patients can't afford, if they can't afford, we shouldn't force them to have. Unless you get this, you will not get improvement. We have to give the maximum support as much as possible, as much as we can. So for structural heart disease, we have to give the whole information that surgery is very important. For coronary, still medical management works, especially if we optimize guideline-directed medical therapy early, we see good outcomes.
Okay. There are some repeated questions, so I'm going to skip some of them. Do we use PO acetazolamide in our setup? Is it available?
Yeah, PO acetazolamide is available in our country. We use it for normal pressure, hydrocephalus, neurology, neurosurgeons usually administer it. We are discussing with my team in our hospital for those patients having refractory fluid overload, but I don't have experience. The trial, the ADWORD trial, is based on IV acetazolamide, and it's not yet incorporated in the guidelines. But the American College of Cardiology guideline of 2022 put acetazolamide as a class 2B recommendation in acute heart failure. I think it's a good idea to do a clinical trial in our setting. It's really affordable, and we can do. It's not harmful to try this molecule for acute heart failure patients, but I don't have experience. But the molecule is available with PO4.
Okay. There's a question about how do you manage patients with pulmonary edema with acute heart failure on shock. I think you addressed that already, I believe.
Yeah.
Yeah. Is there any mortality benefit adding acetazolamide to heart failure patients?
Yeah. It improves decongestion. If we decongest patients early, we can get time to administer guideline-directed medical therapy early. Otherwise, the diuretic, even diuretic, diuresis has no mortality advantage. So diuretic administration, we have to keep a note that diuretic is not for mortality advantage, it's just for symptom relief. That is why we have to de-escalate to the possible minimum dose, and early reduction of diuretic dose is very important during follow-up. So we have to increase guideline-directed medical therapy and reduce diuretic during follow-up.
I get another question about patients with congestion, with cardiogenic shock. What's maybe a related question? What's our experience using inotropic support at the same time with diuresis? Maybe this is something that we practice.
Yeah, we have experience using norepinephrine with diuretic,
okay,
and we have a good outcome. But you have to decide early. You shouldn't buy time, so you have to decide early. So low dose pressure support, at the same time you have to diurese. If you give the decision for nurses for diuretic administration, they measure patient's blood pressure, they find it low, they skip the diuretic dose. Next day, the blood pressure starts to drop. So you will get into a futile exercise later on. So you have to decide early, and you have to also differentiate between hypoperfusion and hypotension. That I want to stress. You have to you have to assess the perfusion status of the patient. Hypotension doesn't mean that that patient is hypoperfused. And you have to doubt also your BP apparatus, the blood pressure, cuff, and the patient's body size. We use big size for a teen patient and so on. So if you really start the low dose pressor early, outcome is good. We have good outcomes. We manage a few patients with Dr. Brook in our ICU, and we had a good experience.
Okay. I think that's why we got a lot of questions. Possibly like it may need an intensive care or high level of care for patients who have cardiogenic shock and pulmonary edema at the same time.
Yes,
that's
yes.
why I think we're getting a lot of questions on this. Yes.
Patient should be, by the way, should be on a monitor, and patients should be in the ICU or high dependence unit, and we have to keep an eye. By the way, a patient with shock and congestion ideally requires an ICU setting and a very dedicated physician or in general a practitioner who should keep an eye to that particular patient to get a good result out of it. They should not be managed at the ward.
We're almost finishing the questions we have. Maybe it's a good question. Diastolic heart failure presenting with acute heart failure, approaching regarding initiation of beta blockers, S inhibitors, and neprisilin.
Yeah, now the term systolic heart failure, diastolic heart failure is becoming obsolete. Now left ventricular ejection fraction is a pillar in the classification of heart failure. So he's meaning heart failure with preserved left ventricular ejection fraction. Heart failure with preserved left ventricular ejection fraction, first we have to identify the cause and manage that cause. That's very important. Etiologic management is very important for those patients. If they are hypertensive, you have to control the hypertension. If they are having atrial fibrillation, you have to manage that. If it is related to infiltrative disease, pericardial disease, you have to address that. In addition to that, beta blockers for diastolic heart failure is just symptomatic relief. It improves, increases the diastolic feeling of the left ventricle in selected individuals, but evidences are now coming. SGLT inhibitors for heart failure with preserved left ventricular ejection fraction is coming. The deliver trial use of dapagliflozin in heart failure with preserved ejection fraction. There are evolving evidence are coming, and it's also incorporated in the guidelines to use these agents. Otherwise, beta blockers are not as a guideline-directed medical therapy for heart failure with preserved left ventricular ejection fraction.
Okay, I think you also answered this during the presentation, but there's still a question. I'll do just 2 more questions and we'll be wrapping up the question and answer session because you need time to answer the form. What is the place of continuous IV loop diuretics for refractory congestion and choice of loop diuretics in this group of patients, furosemide or torsemide?
The dose trial, there is one trial actually involved around 800 patients. The dose trial didn't show difference in terms of outcome, whether intermittent bolus or continuous infusion. But in our setting, it assures us that our patient is getting a diuretic when we administer with continuous IV infusion. Otherwise, there is no difference as far as outcome is concerned between bolus intermittent versus continuous IV infusion. We have experience on furosemide. Globally, I think globally, Dr. Futum might also supplement on this issue. Globally, the experience is IV furosemide, but some centers also use IV torsemide as well. But furosemide is more short-acting and easily titrable, and there is experience with high doses as well, and safety is also well studied to use in ICU or in hospitalized setting. I don't have experience of IV torsemide in acute heart failure.
Yeah, I have used IV furosemide or bumetanide, which is more stronger for dose-to-dose comparison with furosemide. Torsemide has a longer half-life, and it may be, you can use it once a day, and maybe good for outpatient as a pure medication. It can increase adherence, but furosemide, I think, for acute patients who is trying to achieve diuretic goal, I prefer IV furosemide or bumetanide. And the other question was, it's also another good question, Dr. Yetena Tafasa. In case of furosemide in acute heart failure management, is it dose dependent or is it frequency that matters for decongestion? I'll make this the last question.
Yeah. By the way, every patient, as far as diuretic administration is, every patient is different. Even if you have two patients at the same time with the same clinical parameters, the response to diuretic administration is variable. So it should be individualized. So both frequency and dose has an effect on the outcome. So the most important thing is, I think, the monitoring of therapy. I can say. So some patients might, we had a patient who developed significant hypotension with only 20 milligram of IV furosemide. It's a patient individualized management is recommended. I think Dr. Fitzum might also supplement on this.
Yeah, the important thing about furosemide and loop diuretics is there's a ceiling effect for loop diuretics. Unless you get a response with a 40 milligram of Lasix, repeating it every 4 hours is not going to give you a response. So you have to increase the dose to 60 milligram. If they respond and you get a good response with 60 milligram, then you can increase the frequency and you could have a good response. So the dose is also important. So you have to get a response with that level of dose. And then if you get that, then you can keep the frequency every 4 to 6 hours, or you can even make it continuous, like IV drip. But first you have to get the optimum dose, like Dr. Desalew said. You get the response and you can then set the frequency based on how much the patient is responding to that. So there's a ceiling effect for loop diuretics for you to start with. Sorry, I think everyone has got the link for the question. Make sure that you have filled out. Dr. Desalew, is it okay once they complete the form to answer the questions quickly before we end the session?
Okay, good.
If we share it from our end, so we will give you maybe additional 5 minutes. What do you say, Dr. Brooke, Dr. Desalew? I think we've shared it a while ago. Okay.
እስካሁን ወደ 130 ሰው አካባቢ ሪፕላይ አድርጓልና አይ ቲንክ 5 ሚኒትስ የሚበቃ ይመስለኛል።
I just want to add on the point earlier raised about loop diuretics. They have what you call a ceiling effect. So when you get a response, you have to get to a certain dose, and then this is where you see a response. And after a certain dose, your response wouldn't be any different. So there's what we call a ceiling effect. So the question that you asked earlier, if the patient is not responding to 20 milligram, you can increase to 40 milligram. And if you get a good response with that, even if you make it 200 milligram or higher, the response wouldn't be much different. So you get to a level, what we call a ceiling effect. And, going up on the dose wouldn't make any clinical difference in terms of how much diuresis or decongestion you would be able to achieve. Okay. Thank you again, Dr. Desalew. This was one of the most highly engaged webinars we conducted so far. I think the topic is also very interesting, and a lot of people are involved in management of this kind of patients. I think this has been helpful, and the comments that we're getting also suggest that. Hopefully, we'll continue our great partnership with Ethiopian Society of Cardiology and continue to conduct additional cardiology sessions as well. And we hope to have you also on our clubhouse sessions to discuss with the public about some common heart disease.
Yeah, with pleasure. I'm really very happy because acute heart failure is a very common problem that we often encounter and miss a significant number of patients in our daily practice. So yeah, I'm also happy to share this information to my friends, my colleagues in the medical community for a better outcome of our population. I'm also very thankful, grateful for YetenaWeg for your active engagement in providing information. We really lack information, what to do and what not to do in our setting. So I'm really grateful. I attended some of the sessions that you hosted as well.
Thank you. Thank you so much. Dr. Brook, are we good to close the form or?
Yeah, Meto has the introductory reply. I think that's enough. So form close አድርገናል. I think we can continue with discussing the questions.
Do we have the question from our end? Maybe Isra or Caleb, can you share it from your end?
Yes, I will be sharing the screen now.
And then Dr. Desalew can discuss the answers. Thank you.
Okay. So, is it visible?
Yes.
Yes. You can make it a little bigger if you can, or it's okay. Yeah, that's good. Perfect.
Okay.
Yeah. Yeah. The first question is the estimated in-hospital mortality following acute heart failure admissions in the Ethiopian context is the answer is driven from our study we published it in 2020, and in the globe the in-hospital mortality varies from 4% to 11%, but in our setting at Blackline Hospital it was 17%. 17. It is significantly high, and this is it might be much worse in other hospitals because we believe that the Tukur Ambassa Hospital has more expertise and a better resource than other public hospitals in the country. So it is to emphasize that the in-hospital mortality for acute heart failure is very high. So the answer for the first question is C, 17%.
Okay.
The second question is one of the following is independent prognostic factor for patients with acute heart failure. I have clearly emphasized it in my presentation. So the answer is systolic blood pressure And BUN as well is an independent predictor. Others are not included as a predictor for independent predictor. Though presence of cardiorenal syndrome is not an independent predictor. The most important independent predictors are systolic blood pressure and the BUN level above 37 milligram per deciliter. If the systolic blood pressure is less than 140 millimeter mercury and above that, it has a linear relation with mortality. So the answer for this question is A, systolic blood pressure. This is a narrow pulse pressure in acute heart failure reflects presence of regurgitant lesion, high output heart failure, intravascular fluid deficit, chronicity of the heart failure. So narrow pulse pressure means the intravascular space is empty. So it is a marker for intravascular fluid deficit. So this is a clinical assessment for fluid deficit when you encounter such type of patients. Rather than diuresis, they might even need fluid administration. Sometimes patients' acute heart failure might be precipitated by fluid loss following excessive diuresis, following vomiting, following diarrhea. We often encounter. And on top of that, when they present with acute heart failure, we might wrongly diurese them and worsen their heart failure state, especially we might compromise the kidney function. So those, this is to guide us that vital sign is very important in acute heart failure management. For the answer for this question is C, intravascular fluid deficit. This is about diuretic administration in acute heart failure. A continuous IV infusion is superior to intermittent bolus dose. Oral therapy is as effective as intravenous route in a cooperative patient. Baseline raised creatinine is not a contraindication for diuresis in congested patients, should be avoided in hypotensive patients despite their perfusion status. So this is a very important question about our diuresis. So continuous IV infusion is almost the same as intermittent bolus dose. Dr. Futsum also supplemented about the saline effect. We have to give them intermittent bolus dose until we get the dose for that particular patient. We start with low and go slow, assess patients frequently. It's the same as far as outcome is concerned with continuous IV infusion. Oral therapy should be avoided. In acute heart failure, patients should receive intravenous furosemide because the bowel is congested, absorption is impaired, so the efficacy of diuretic will be compromised using oral therapy. Baseline raised creatinine is not a contraindication for diuresis in congested patients. Yes, it could be a cardiorenal syndrome. So congested patients should receive diuretic despite the creatinine level. That is very important. Should be avoided in hypotensive patients despite their perfusion status. So hypotension is not the same as hypoperfusion. So even if the perfusion status is okay, still this with low blood pressure, diuretic should be administered. So the answer for this question is C. C. Baseline creatinine, raised creatinine is not a contraindication. The last question is about oxygen administration in acute heart failure. We often administer oxygen to every patient with acute heart failure. That should not be practiced. It is indicated only for those patients who really desaturate. Oxygen level is less than 90%. This is a class 1 recommendation in patients with acute heart failure. And non-invasive positive pressure ventilation is superior to intranasal oxygen for early relief. And early intubation and mechanical ventilation fasten recovery. So the answer for this question is B. indicated only for those with oxygen saturation less than 90. Overzealous oxygen administration is not recommended because oxygen is also toxic. It's also vasoconstrictor. So for those patients having a normal saturation level, we shouldn't administer. So these are the response for the patients. Thank you.
Thank you so much. I think that was an excellent session. We discussed in detail about management of acute congestive heart failure. We went through all the questions that you have, and also addressed the question that we presented for you. I think we have corrected the form. There was some issue initially about the scoring. We have corrected the form now. So all of you who have submitted your name and submitted your answers should be able to get your scores. And we'll be in touch with the Cardiology Society to get you your CEU credits as soon as we can. Esra, Dr. Caleb and Brooke, if you want to add something, say thank you to Dr. Desalew. I'll let the floor for you. You can wrap up the session after your input. And Fozia, you asked where we can get the video. It will be uploaded to our YouTube channel. I'll be sharing the link in the chat group while Mr. Brooke and Caleb say something. I'll share the YouTube channel. You can also access our previous CME sessions that we've been conducting for the last 2 years on a variety of topics, so you'll be able to get it there.
Thank you, Dr. Kusum and Dr. Desalew. It has been a great session. We actually managed to wrap up on time. It's now 7 p.m. local time. So we'd like to thank everybody who participated today. It was a very engaging webinar we had. We also would like to thank our esteemed guest, Dr. Desalew Mekonnen. It was a really great and insightful presentation. Don't forget to join our social media groups, Telegram groups, channels, and don't also forget to follow us on Facebook, Instagram, Twitter, and LinkedIn as well. We'll be having many more webinars. This is just the third one on this calendar year. As I've said earlier, we plan to have around 40 webinars, so that gives us more than 30 webinars to go. So make sure to subscribe, to follow, and we will keep you up to date, and we hope to see you on our upcoming webinars as well. If you have any question, don't forget to email us or ask in our groups as well. We will try to respond as soon as possible. Regarding your certificates, EMA will be issuing the certificates in 1 to 2 weeks, so it might take up to 2 weeks.
Not EMA, Cardiology Society.
Sorry. ESCP will be issuing the certificates in 1 to 2 weeks, so we ask you to stay patient and bear with us. Everyone who scores above 50 will get the certificates. So that's all from our side. Thank you.
It was a very good discussion. ዛሬ ብዙ ፓርቲሲፔሽን ነበረን፣ ብዙ አቴንዳንስ ነበረን። ዶክተር ደሳለውን በጣም ቆንጆ በሆነ መልክ፣ በተለይ ደግሞ በጣም ፕራክቲካል በሆነ መልክ ዴይሊ ፕራክቲስ ማድረግ የምንችላቸውን ነገሮች ላይ ፎከስ አድርጎ ነው ዲስከስ ያደረገን። ሶ አይ ኤም ቬሪ ቴንክፉል ፎር ዚስ ፕሬዘንቴሽን ዶክተር ደሳለው፣ ቴንክ ዩ። ኤንድ ቅድም ፍፄ እንዳለው ከዌቢናር ውጭም ሌሎች ሴሽኖች አሉን ለፐብሊኩ ደግሞ ታርጌት ያደረጉና እዛ ላይም ያንተን ተሳትፎ ብናገኝ የሚጻፉ አርቲክልስ አሉ። አትሊስት ካርዲዮሎጂ ላይ የሚጻፉ አርቲክሎች በሜዲካል ስቱደንትስ በጀነራል ፕራክቲሽነርስ አሉ። እነሱን ሪቪው በማድረግ አዌርነስ ክሪኤሽን ፎር ዘ ፐብሊክ ላይም ታግዘናለህ ብዬ አስባለሁኝ። ኤንድ ኦን አወር ኮንቲኒንግ ደግሞ ኮንቲኒየስ ፕሮፌሽናል ዴቨሎፕመንት ኢንክሉዲንግ ሌሎቹ እንደ ሜንተርሺፕ ያሉ አክቲቪቲዎችም ላይ በደንብ ፓርቲሲፔት አብረህን ታደርጋለህ ብዬ በጣም አስባለሁ። ቴንክ ዩ ቬሪ ማች ኤንድ ሁላችሁም አቴንድ ያደረጋችሁትን በጣም በጣም ማመስገን እፈልጋለሁ። ሃቭ ኤ ጉድ ናይት፣ ሃቭ ኤ ጉድ ዴይ።
Thank you, Dr. Desalew. I'll leave the last speech for you.
I'm really grateful, as I have already said. Thank you very much for the invitation. I'm really I'm interested to participate in the activities that Dr. Brooke already mentioned, and I am at your disposal to help the community as well as the medical community as well as the general community in addressing cardiovascular issues. Thank you very much, Dr. Susan. It was a pleasure to know you as well. And,
Same here.
Yeah.
All right. Thank you, everyone. For everyone who hasn't left yet, just to give you dates about our next upcoming CME webinars. On February 24th, on Friday, there is an Ethiopian Health Exhibition Expo. We'll be conducting some of the CME sessions from there live on Friday, February 24th. We'll have a live session. It's also, again, cardiology topics about hypertension management. It's something very common. You probably see a lot of patients with hypertension every day in your practice, so it's not something you don't want to miss. We'll be sharing the link in our professional Telegram group. And February 25, for anyone working primary care or managing patients with polytrauma, we'll be having a guest from New York University, Columbia University, to discuss about road traffic accidents and management of polytrauma. So both very interesting topic coming in 10 days or 2 weeks time. So stay tuned and follow our channels. This is all from our webinar today. Have a good Saturday. Bye.